Lastly, we're going to talk about inflammatory infiltration for the mechanismic part of this presentation. So inflammatory infiltration is the production of proteases and cytotoxic mediators that further degrade elastin and collagen, which decreases smooth muscle cell density and leads to the pro-inflammatory state that weakens the wall to the point of AAA classification. So as we can see in this figure, it's depicting a normal aorta, which has very few inflammatory cytokines, just the smooth muscle cells and elastin. And then in the aneurysmal aorta, we have this huge plethora of inflammatory cells that come and infiltrate the different layers of the aortic wall. And if we're looking at figure 6, this is from an article that was discussing the relationship between the inflammation and the progression of AAA in rabbits. So figures A and C are from 2 weeks post-op, and figure B and D are from 4 weeks post-op. And the SUV max, which is the this axis, is the metabolism rate. And as we can see, the increased aortic rate is increasing in the 2-week period, as well as the percentage of the CD68 cells, which is a biomarker for inflammation. And in the 4-week period, we're seeing the opposite, which is a decrease in the AAA growth and decreased CD68 decreased CD68 in the 4-week period as well. So it kind of just shows the importance of the inflammatory cells in the beginning of the inflammatory process rather than the end of it. But ultimately, this is just depicting the final step of formation of the AAA. So now we're going to talk a little bit about dissection. So dissection is the most fatal case that can happen from AAA, and it's an increased risk related to diameter. So the larger the diameter, the larger your risk for dissection. And it leads to very dangerous hemorrhaging. As you can see in this picture here, the blood starts to pool in to the false lumen because the cell wall becomes too weak to withstand it. And it leads to hemorrhaging, and it's usually fatal because, like I said, you don't have time to get to the hospital in time for treatment. So it's usually fatal. And that's just a little bit about dissection. And then just touching briefly on treatment. So there's 2 main types of treatment. There's open repair and endovascular repair, which both have pros and cons. Open repair requires a lot more skill, so a lot more skilled surgeons would have to perform this one. And it also has an increased risk of infection and recovery time because it is an open surgery. And then the endovascular repair only applies to 40 to 60% of patients because of the anatomy. It only applies to them. And it does have a shorter recovery time, and it does have a lower mortality rate of 30% in comparison to the open surgery, which is about 40%. So the endovascular repair is the one that's used more commonly if it's applicable with the anatomy of the patient. So implications and significance. Testing is based on diameter, which does have a strong correlation to the chance of rupture, but it's not a foolproof method of testing, and it doesn't necessarily mean that if you have a larger diameter that you do have a larger chance of rupture, but this is the best correlation that we found for testing, so that could definitely use some more further research. It's largely asymptomatic, which I mentioned, so even if we have testing, it's hard for patients to come in and have a way of detecting it in patients. So that's another place of research that we can continue to look into. It does have a high mortality rate. It's very prevalent. Heart disease is one of the biggest problems that we have. So that's just another significance of why we should do more research into it. And then lastly, the treatment is an invasive surgery. So it is pretty important that we look more into it because these are higher risk patients. These usually have comorbid diseases and stuff, so it's important that we look for future ways of different treatments. And these are my references, so thank you for my presentation. Hope you enjoyed.